I'd like to thank the East Online Education Committee for allowing me to participate in this webinar about our East Practice Management Guidelines. I'm Nicole Stassen, the immediate past president of the East Senior Association for the Surgery of Trauma, and I am a trauma surgeon at the University of Rochester. What we're going to talk about today are East Practice Management Guidelines, the past, the present, and the future. I have nothing to disclose other than I'm very proud of our East Guidelines, East Practice Management Guidelines, both the way we started creating them and how we're creating them now. I think we've come a long way, but other than that, I have nothing to disclose. So the Practice Management Guidelines were introduced to the Eastern Association for the Surgery of Trauma in 1994 by then President Michael Rhodes. He was one of the founding members of East, and he felt strongly that we as trauma surgeons should be engaged in improving the care of our trauma patient. His presidential address that year was entitled Practice Management Guidelines for Trauma Care, and what he hoped to accomplish was that there were 5 purposes of guidelines that we as trauma surgeons should be creating. They should assist us in clinical decision making. They should help educate individuals or groups. They should be able to assess the quality of the care that we're giving, and also guide allocations of resources. A secondary benefit, but certainly not the main purpose, was also reducing risk for legal liability within our specialty that can on occasion become litigious. What he had hoped for with our practice management guidelines, that we would no longer just have physician protocols and nursing protocols, but really patient management protocols that would merge both the bedside care provider as well as the physicians, physician extenders, and entire care teams in optimizing trauma patient care. What he talked about also during his presidential address was that with healthcare reform looming, and certainly it doesn't seem like that's gone away since 1994, that there certainly was cost containment and improved efficiency that would be focused on. And really that central to this would be, again, the concept of practice management guidelines. And although some had started to exist at that time, making sure that we were participating on the ground floor and controlling some of this dialogue was vital. What was done at the behest of Dr. Rhodes was a work group of approximately 20 East member trauma surgeons, many of who from there on in the future went on to be presidents of the Eastern Association for the Surgery of Trauma, including Michael Pasquale, Tim Fabian, Kim Nagy, John Morris, and many, many, many more. They set up a work group where they believed that we as trauma surgeons should participate again in endeavors to improve the care of our trauma patients and guiding future research. With this consensus conference created, a basic framework was set up where the hope was that national societies, with each taking the lead, would select topics important to the care of the trauma patient, review evidence available, and then develop practice management guidelines, which would then allow for development of institution-specific protocols. Each institution, as we all know, can be a little bit different, both in our geography, our resources, the patient populations that we see. Are you an urban inner city trauma center, or are you a more rural-based center? Certainly, your needs and manpower may be different in those situations. With that in mind, they utilized a methodology developed by the Agency for Healthcare Policy and Research, which included selecting topics, then selecting a panel, or as we called them, work groups for practice management guideline development, clarifying the purpose and scope of the guideline, the goals, assessing the evidence, and then, of course, moving forwards towards drafting guidelines, and then also not just drafting them, but validating the content and eventually implementation of those guidelines. With the 20 trauma surgeons that were included, each member selected topics, and topics were assigned to a chairperson, and the guidelines were created by a committee using, again, the framework, looking at the evidence that was available, stratifying that into Class 1, Class 2, and Class 3 evidence. We'll talk about that a little bit more later. And then making graded recommendations, Level 1, Level 2, and Level 3, based on the data that was available. The guidelines that were created were reviewed and revised, and they were submitted then not not the way we did it a little bit later, but they were submitted to the East Program Chairman, then to the East President, and then to the East Board for initial review before they ever went out to the membership. Those revised guidelines were then presented in 1997, just 3 years after Dr. Rhodes' address, to the East Annual Assembly, and revisions were made based on the comments and suggestions from membership. Here are just a few of those early guidelines. Practice management guidelines for venous thromboembolism, still a problem that we face today. Practice management guidelines for the screening of blunt cardiac injury. Certainly the practice that we have now is much different than we had back in 1997. Cervical spine injuries, still a vexing challenge. One of the initial guidelines was about identifying cervical spine injuries after trauma. And also penetrating intraperitoneal colon injuries. And if you look at the authorships on many of these, you'll see much of the future leadership of East involved in this very, very important process. Out of that work group was developed in 2000 also a primer on guideline development. And what this was a white paper document describing what, where, how, when, and why we would perform guidelines. The practice management guideline steps that were developed were an identification of resources, oftentimes utilizing a medical librarian, grading of the quality of references, where Class 1 were prospective randomized studies, Class 2 were prospective non-comparative studies, or retrospective series with controls, or Class 3 retrospective analyses, including case series database, and registry reviews or case reviews. From that, levels of recommendation were made, where Level 1 recommendations were considered justifiable on scientific data alone and really based on Class 1 data. And if you remember what Class 1 data was, prospective randomized studies, certainly we don't have a lot of those necessarily within a lot of topics within trauma. Level 2 recommendations were justifiable by scientific evidence and strongly supported by expert opinion, utilizing mainly Class 2 and Class 3 data. And Level 3 recommendations were supported by available data, but really just Class 3 data. And when you look at that, that's the retrospective case series and registry studies that are actually quite common within our trauma literature. There was a major expansion of practice management guidelines after the development of that primer. Really, practice management guideline development was off to the races, and an enormous amount of work was done. There were multiple committee chairs between 1997 and the present, working on organizing practice management guidelines, and innumerable East member volunteers that actually reviewed the literature and created the guidelines. In 2012, Andrew Kerwin was the committee chair for the practice management guideline at that point, an ad hoc committee. He moved our guideline development in a few different ways. First, he created subsections within the Practice Management Guideline Ad Hoc Committee where we had subsections in trauma, critical care, emergency general surgery, and injury prevention. Classically, we had really only written trauma practice management guidelines up to that point, but with the broad base of our specialty, making sure that we were evaluating critically how we practice critical care, emergency general surgery, and particularly injury prevention were recognized as separate and absolutely important entities. The other thing that occurred during Andrew Kerwin's tenure as the head of the Practice Management Guideline Ad Hoc Committee was the conversion from our original primer in 2012 to grade methodology. So you might say, we were off to the races. Our original primer worked well. Our guidelines were well received. They were useful in practice. So why change? Well, there were a few things. With the advent of the development of guidelines, there were varying approaches to rating evidence and formulating guidelines by different societies. Not everybody did things the same way we did. And this really undermined the quality and trustworthiness of guidelines. So better standardization was important. The Institute of Medicine around that time also published standards that needed to be used in order to produce trustworthy guidelines. You needed a transparent process. You needed to manage conflict of interest, which really wasn't addressed in our primer. A multidisciplinary guideline development group was ideal. You needed systematic review interaction and clearly describing a summary of the evidences and differences of opinion, which wasn't always seen as well in some of our guidelines that were developed using our original primer. There's nothing wrong with the way we developed the guidelines, but we could do better, and certainly ever better is an important thing to EAST. So what is GRADE? So GRADE is actually an acronym standing for Grading of Recommendations, Assessment, Development, and Evaluation System for developing practice management guidelines. This was developed by a work group to meet those IOM standards that we just talked about and was adopted widely by over 60 national and international organizations even back in 2012. As an organization, the PMG committee, the EAST Board of Directors felt it was important to upgrade how we approached rating evidence and making guideline recommendations, leading towards, again, a white paper about our change to using GRADE methodology rather than our original primer. There was nothing wrong with the way we did it, but we could always do it better. So what is the overall concept of GRADE? It's really a two-part process. The first part, grading the evidence for a particular question, and then secondarily, making recommendations based on this evidence in combination with other factors important to clinical decision-making, taking patients into account and not only the literature that was available. There's multiple steps to GRADE, and certainly it's more complex than our original primer. First, framing the question. Second, defining the outcomes. Third, a systematic review of published literature. Fourth, grading the evidence available. And fifth, making recommendations. So let's break these down a little bit. So framing the question. If you look at our original guidelines, most of the questions that we had were informal questions. What should we do for blunt splenic injury? How should we manage hepatic trauma, etc.? But in GRADE, that informal question needed to be converted to a specific question that really had a binary answer. And the format of the question was in what was called a PICO format, where you need to clearly identify the patient population affected, the intervention being evaluated, the comparator or comparators that you would utilize, and then also the outcome that you were expecting. So our original question might have been, should angioembolization be performed to improve splenic salvage for patients treated with non-operative management? Now the question would read, in patients with blunt splenic trauma, identifying the patient, should angioembolization, identifying the intervention, be performed compared to no angioembolization, the comparator, to improve splenic salvage for patients treated with non-operative management? Again, the outcome. So the PICO questions really drive this, framing that question, it drives a systematic review of the literature search and the guideline development. Each informal question, however, could lead to multiple PICO questions. So let's go back to that splenic example. So maybe angioembolization was one intervention. Should you be checking serial crits? Should you be repeating scans? All of those individual components now would lead to a second question, and all outcomes really needed to be considered. So it exponentially increased the questions that were being asked in each guideline. Defining the outcomes is also critical. The outcome for each PICO question is categorized as critical for decision making, important but not critical, or of limited importance. So if you looked at the outcomes that we were evaluating back to that splenic angioembolization question, the critical outcomes might be mortality or splenic salvage and need for transfusions, where limited important outcomes might just be cost and resource use, with important outcomes including things like contrast allergies. Again, in a way, grading the outcomes that you're evaluating to their level of importance. So the way we ask the questions in GRADE sets the framework, it sets the basis, and is a frame step different than what we were doing in the past. Again, that binary answer. Should you do this, yes or no? The other big change was how the published literature was reviewed. Certainly, reliably identifying all the published data is imperative, but also meta-analyses were done in order to combine the data so you could give an overall estimate and confidence interval for the effect size that that intervention might have. So instead of looking at each piece of literature separately, what you would look at is the scope of literature, and for each outcome in each paper, was that outcome studied? If so, combining it with that outcome in the next paper, and in the next paper, and in the next paper. Complicated, yes, but certainly more thorough than what we had been doing. In grading the evidence was graded for, again, each outcome for each PICO question. So when we were rating the quality of the evidence, we had to consider the confidence in the estimate of each effect to see whether that was likely to be correct. So also looking at bias in the studies. So looking at the levels, looking at the grading or the rating methodology, the real mission was to be transparent in how we were assessing the quality of the evidence. So even not all randomized trials were created equal, and not all observational studies were created equal. So what was evaluated in each piece of evidence was it high quality, moderate quality, low quality, or very low quality? With high being that you're very confident that that study, that the true effect was pretty close to the estimate. And with a very low quality study, that you really had very little confidence in that evidence. When you look at what literature or when you look at evidence, it could be upgraded or downgraded, where randomized trials might be initially rated high, but they would be lowered if there was a serious bias or inconsistency, or higher if there was a large effect seen or a lower effect seen. And with observational studies that might start off low, they may increase because of, again, a large effect and no confounding factors seen within the study design. The recommendations that are made through grade are also different. Remember, we had the level 1, level 2, and level 3 recommendations in the old primer. And the recommendations in the grade methodology, you're really using those evidence profiles to provide a detailed judgment about the quality of evidence for each outcome, looking at the ratio of benefit to harm for patients. Were also considered in making recommendations. That wasn't true in our original primer. In our original primer, if there was an intervention that could potentially be harmful to patients but was very effective, that might still be at a higher level of recommendation, where that wouldn't be so in the grade methodology. Also, there's only 2 recommendations that could be made: a strong recommendation or a weak or conditional recommendation. And it was set for what you would recommend to patients, what you would recommend to clinicians, or even what you would recommend to policymakers. And it would be changed a bit. With a strong recommendation, the expectation that most patients would want the recommended course of action. And for weak recommendations, that most patients wouldn't want to participate in the recommended course of action. I know it sounds pretty confusing, and grade, as you get to know it, becomes a lot more clear. But when you look at it in summary, it all comes down to the question you ask with a binary answer, looking at the available studies that look at that question, looking at the different outcomes to that question. So again, if you go back to the spleen example, looking at whether you use angioembolization for splenic salvage, whether you have an outcome, and that's the binary question, looking at the studies, and with the outcome looking at improvement in mortality, improvement in splenic salvage, etc. For each of those outcomes, you generate basically a scatter plot with a meta-analysis, looking at whether the literature favors that intervention for that outcome, or it does not favor that intervention for that outcome. And for each piece of evidence that you see, you're not just looking at, was it a randomized control study, but what is the quality of that study? What is the question that was asked? What is the risk of bias in that study? So a much more thorough and, in many ways, transparent way of evaluating that. Once the evidence is all gathered for each outcome, then the recommendations, strongly yes, or a weak recommendation where it's really a no answer. So after we switched to grade in 2012, we had a bit of a steep learning curve, and Elliot Hout took over the practice management guideline committee shortly after we switched to grade. It transitioned then from an ad hoc committee to a standing committee as well. And what we really needed, and what both Dr. Kerwin or Dr. Hout, and then also Dr. Hout's predecessor or successor, who we'll talk about in a moment, expansion of individuals within EAST that were great experts, that understood the methodologies, that we knew we were turning out work product that was accurate and important. Under Bryce Robinson's leadership over these last 2.5 years, we have over 60 practice management guidelines developed. A fair number of those are in grade format. We still have some older guidelines that are in our older format, and some are being converted to grade depending on the topics, etc. We're continuing along those 4 pillars of trauma, critical care, emergency general surgery, and injury prevention. So not just isolating to trauma practice management guidelines as we had started with as an organization. We've also increased our collaboration with other organizations, specifically the Cervical Infection Society, the Pediatric Trauma Society, and the Committee on Trauma, where the EAST Practice Management, where EAST is now partnering with the Committee on Trauma Performance Improvement Committee or Performance Improvement and Patient Safety Committee to utilize our EAST guidelines as the backbone for quality metrics. That through the leadership of EAST past President Don Jenkins, and of course Ronnie Stewart with the American College of Surgeons COT. So that's it. Looking at guidelines are great, but making sure that we're operationalizing those guidelines and now doing that on a more national scale. In the NASM report that just came out, certainly EAST was recognized in the civilian sector as one of the leaders in the development of hospital-based trauma care guidelines. And certainly that was built on the beginnings with Dr. Rhodes, those initial 20 surgeons that started our trip through our practice management guideline experience, the development of our original EAST primer, and then our evolution to even more rigorous methodology through grade, and that's continued through the most recent practice management guideline committee chairs. There are, of course, we have come a super long way, but there's a lot more to be done, and it's very exciting to look at where we'll be 10 years from now, 20 years from now, when we're looking at evidence-based reviews and practice management guidelines for our trauma patients. My fondest belief is that EAST will continue to be on the cutting edge in making sure that we're reevaluating our methodology, reevaluating the questions we ask, and making sure that our practice management guidelines help drive and improve care for the trauma patient. I thank you very much for taking your time, for hearing a little bit about the history of the practice management guidelines and the Eastern Association for the Surgery of Trauma. Thank you very much.